In the following tracing, we will discuss the interest of anti-tachycardia pacing as first-line therapy in the VF zone. This is an old device, where this kind of programming was not possible. You can see initially a sinus tachycardia, and then the onset of a monomorphic, regular tachycardia, but detected in the VF zone. So initial diagnosis of VF, and then onset of the charge of the capacitors, since in these devices the shock was the only possible therapy in the VF zone. At the end of the charge, the electric shock is synchronized on the ventricle, but is delivered in the vulnerable atrial period. And we see that this shock is efficient at the level of the ventricle, but will induce an episode of atrial fibrillation. So of course, an electric shock is the only therapy that is able to restore sinus rhythm in case of ventricular fibrillation. But when the tachycardia, like in this example, is regular and monomorphic, we know that the electric shock can be efficient, but you also have a pro-arrhythmogenic effect at the level of the atrium, but also at the level of the ventricle, is painful for the patient, that can have important and psychological implications for the patient, and of course also increases the consumption of the batteries. Therefore, there have been different studies demonstrating the potential interest of anti-tachycardia pacing for this kind of arrhythmia, even when they are detected in the VF zone. We will see now in this second patient the functioning of anti-tachycardia pacing in the VF zone. You can see the onset of a stable monomorphic tachycardia detected in the VF zone. Once the VF counter is filled, simultaneously there is the onset of the charge of the capacitors and the delivery of an ATP sequence. The ATP has been efficient after 1, 2, 3, 4, 5 consecutive cycles classified VS. There is a diagnosis of return to sinus and interruption of the charge of the capacitors. This is now a second episode of ventricular arrhythmia of the same patient, detected in the VF zone. Once the VF counter is filled, then starts the charge of the capacitors and the delivery of the ATP sequence. So the burst here is inefficient with the persistence of the arrhythmia. So there is no interruption of the charge of the capacitors, and the shock is delivered without delay and with efficacy of the shock and return to sinus rhythm. So in the first case, the burst has been efficient, and therefore the shock could be avoided. That's the main advantage of these therapies in the VF zone. But there was a partial charge of the capacitors that increases the consumption of the batteries. In this example, you can see that if the burst is inefficient, then there is no delay between the onset of the arrhythmia and the time of delivery of the shock. This third episode in the same patient highlights the importance of programming the return to sinus counter. It can be programmed at 3, 5, or 7. In this patient, it has been programmed at 5. You can see that once the diagnosis of VF has been realized, there is the onset of the charge of the capacitors. The burst is efficient with a reduction of the arrhythmia, but there is a re-initiation of the arrhythmia. There has been 3 consecutive VS, so not enough, because the VS counter has been programmed at 5. Therefore, there is no interruption of the charge of the capacitors. And then the shock is delivered at the end of the charge, and the shock is efficient. In the guidelines, there is an indication to program as a first-line therapy ATP while charging. It is a class 1 indication for tachycardia up to a rate of 230 beats per minute. So, to program ATP in the VF zone, there are two options. The one that we have seen, ATP while charging, which is the default setting, and the second option, which is ATP prior to charging. When the VF counter is filled, then the ATP is delivered. But there is no start of the charge of the capacitors. Once the ATP has been delivered, then the device checks if it has been successful. If it has been successful, there is no charge of the capacitors, and there is a huge interest in the terms of consumption of the batteries. If the ATP has been unsuccessful, then starts the charge of the capacitors, after a delay of around 2 to 3 seconds.